So I'm just going to hand it straight over to Michelle, and she's going to introduce herself.
Yes, so thanks so much, everyone, for giving me the opportunity to talk to you today. Actually, I haven't presented this work in a little while, so it's lovely to be able to tell it. So my name is Michelle Hayes. I am a clinical academic, so I work about 1.5 days a week in East London in Newham with a specialist children and young people's service, where I mainly sort of lead the care for children with cerebral palsy and motor disorders. And then for the rest of the week, I work at the Institute for Child Health in PPP, so Population Policy and Practice, doing mainly academic work and some teaching. And today, I wanted to mainly talk about some work that's completed, which is some work in Nepal. But the idea really is to sort of showcase some of that intersectionality between neurodiversity, cultural diversity, and social adversity.
Michelle, can I just interrupt for 1 second? So everyone, if you have any questions, can you please wait till the end? And we have a Slido. I've put it in the chat. The code is #seminar2704, and we will do Q&A afterwards. Thank you.
Okay, thanks, Diana. So as I said, the bulk of the work I'm really going to describe a mixed methods study that I did in Nepal, looking at trying to estimate the prevalence of autism in Nepal, but also try and explore the understanding of parents and professionals as to sort of what atypical child development is. And then very briefly at the end, I'm going to mention the UK-Japan Neurodiversity Meets Cultural Diversity Collaborative, and then introduce you to some work that we've just started doing in East London. So I think I've told you where I work, but that's a picture of the Olympic Park in Stratford. It's probably the nicest picture of Newham that you'll see. And then the other part of the week at Great Ormond Street. But I'm also a mother of 3 children, and I work a lot in global health, and I'm the lead for the Neotree project. And I'm also involved in teaching for acute peds and health needs assessment. I have a broad research portfolio, which I won't really go into, but I think one of the things I just wanted to highlight is that, that there's commonality across the research projects that I have that are around team science, around trying to take a multidisciplinary approach to the work, into trying to adopt a systems thinking approach, and where possible, trying to involve families, children, young people, healthcare providers, whoever it is that we're working with the research process as much as possible. Newham is a fantastic place to work. So it's that's where the seat for my clinical work is. It's extremely diverse, both in terms of ethnicity, in terms of language and culture. So as I said, the bulk of what I'm going to talk about is the work in Nepal. Hopefully it'll be of interest to you. Before I just go into that, I just wanted to say a little bit about positionality. I am a white female, broadly speaking, neurotypical, and so I am aware of that. In the presentation, I've tried really hard to use terms that our PPI group have said they prefer. So you might notice throughout that I talk about autistic children or autistic boy or autistic child, and that's very much driven by what the families preferred. But please, forgive me if I'm using any terms that people disagree with. I'm very happy to talk about that and learn how to do that in a more sensitive way. So don't be afraid to speak up and tell me. So I'm going to tell you about the aims of the project, the study overview, and then obviously the results. So the aims of the project that I did in Nepal when I was a clinical lecturer funded through the NIHR were twofold. Firstly, to examine the parents' and professionals' understanding of typical and atypical child development. So, and I use those terms because we included all range of child development, so not just autism, in both rural and urban Nepal, and also to facilitate some cross-cultural comparisons between the UK and Japan. That section, which is in a smaller font, didn't go quite as well as we'd wanted initially, but we're gaining traction on that now. And the second aim was to estimate the prevalence of autism in school-age children living in rural Nepal using a population-based screening tool. So this is the first ever prevalence study of autism within Nepal. And it goes without saying that none of this work has been done just by me. These are a few of the collaborators and my supervisors are shown there. So for those of you who don't know, Nepal is the most beautiful country. This is a map of Nepal. And this is taken from the website of our research collaborators in Kathmandu, so mother and infant research activities. The first circle there you can see is Kathmandu, which is the capital of Nepal, and then Makumpur district, which is slightly south and west of Kathmandu, which is the rural site for this subject, project. So key issues for Nepal, as with other low-income countries, and just to note, it's the only LIC outside of sub-Saharan Africa. The high birth rates and the falling death rate, which has led to a greater sort of survival in childhood, but also marginalization of children and adults living with a disability, and in particular difficulties around hidden disabilities, or not recognizing things like autism or ADHD. And when I started working there really was no service whatsoever, health service for children with a disability. More than 80% of the population are rural. This is a picture of Makumpur. It's really beautiful. So it sits in the foothills of the Himalayas. And this is the urban site, which is Kathmandu, a vibrant, jostling mess of a city, which is both a delight and sometimes frustrating to visit and work in. So the wider context, as I'm sure everybody is aware, is that of the Sustainable Development Goals, which really have brilliantly and in a timely way put a focus on not only survival but thrival. So what happens after a baby survives, or a child? How can we try and optimize a quality and longevity of a sort of healthy life? So this project that I'm telling you about was not my main clinical lecturer project. This was sort of a sub-study of a larger piece of work that I was doing, which was to evaluate the long-term impact of a cluster randomized controlled trial of women's groups. And I'll just take a slight diversion from the autism just to tell you a little bit about that study so you can understand the context. So I just want you to imagine a drug that, if given to mothers during pregnancy, that would reduce the risk of the death of their newborns by 30%. And that drug had no known side effects, and you only had to give it up to a third of the pregnant population, and it was really, really cheap. So my question to you is, what might that look like? And I can tell you it wouldn't look like a drug. It looks like this. So the Institute for Global Health, along with teams in Bangladesh, Nepal, India, and Malawi, ran a series of trials and intervention development looking at the impact of participatory learning action groups. And this is a picture of them. And some of these slides here, a huge thanks to Audrey Prost from the Institute for Global Health for sharing with me. And I'm going to flick through these, but what the meta-analysis of these studies showed, as I said, that there was a reduction in neonatal and maternal mortality. And if you know, a third of the pregnant mothers were enrolled in these groups, then you had that impact across the piece. So now this has been rolled out across numerous areas now. The WHO have taken it on to be rolled out across all rural low-income country settings. And rather kind of interestingly and excitingly for us in the UK, we're also looking to do reverse innovation of this. So south to north learning, trying to take this approach and test to see if it will work within a high-income country setting. And that work has been led by Monica Lackenpool and also now Logan Manikam, and I've been a sort of small part of that project, which has been hugely exciting. So I'm going to flick through these, but the question was, 10 years down the line, after these women's groups had been taken on board by the WHO to roll out, is what happened next? So the follow-up for the trials was only up to 4 weeks. The question was, could that magical, the drug or that intervention also result in improved chances of survival in children after 4 weeks of age? Or would infants with greater risk of disability survive who would otherwise have died? So what happened next? And that's what the crux of my clinical lectureship was all about. So I did a 10-year follow-up study, and my main outcomes were child and maternal mortality. But I also wanted to look at childhood disability, cardiovascular risk, and cognitive outcomes. Oops. We managed to access brilliantly. I had a brilliant team on the ground in Macronport, but we managed 80% of households in Macronport for successful follow-up, and we also managed to get proxy outcomes for the remaining households. So we had outcomes for nearly 98% of the follow-ups. This data is published, but this is a flowchart of the families and the children and how we followed them up. But of note for this presentation, there were 2 rounds of follow-up. The first one looked at disability, and the second one looked at autism. And the results showed that there was a non-statistically significant reduction in childhood mortality and disability in the intervention arm compared with control 10 years down the line, which was pretty remarkable. But I think the main sort of, because that wasn't statistically significant, I think we could say with a good degree of certainty that the intervention didn't mean that babies that were more likely to die later died, but actually survival was at least as good, if not better. So why did I start this project? So, well, when I was thinking about how would we screen or measure for disability within rural Nepal, and the epidemiological measures that we have to look for disability are really not great, and they remain not great. And they also focus predominantly on things that you can easily see. So they would ask families whether the child could walk, and if not, how far. They would ask whether or not they were hearing impaired or visually impaired. But there was hardly any questions or any data on hidden disabilities. And when we started looking at this, it became very obvious. There's no word for autism in Nepali. There was very little understanding of what so-called hidden disabilities might look like, or what autism might look like within this population. And so it became clear that I needed to do a really good qualitative piece of work before doing the prevalence study. So I think background, this is sort of well known. I'll just go through this quickly, but research around childhood disability in low-income countries is scarce. there's barely any data on autism or ADHD. There still remains controversy about sort of the use of autism as a diagnosis within settings, within low-income country settings. And there's also uncertainty around how people with these kinds of behavioural characteristics are understood in many under-resourced or non-Western settings. So, you know, an example of that is when we were doing the training on childhood development within the Nepali research team, we were talking about eye contact, which is, you know, one of the things that we look for when we're doing an assessment for autism. And within the Nepali setting, it's not considered polite, especially for girls, for women to have direct eye contact with men. And it's not considered usual or polite for children to have direct eye contact with their seniors. So there's a very hierarchical cultural overlay to, you know, to eye contact and that behavior. So again, it became clear that the things that we would think about within a Western cultural setting might not be applicable to Nepal. Yeah, so there's virtually no data at the time of the study on population prevalence of autism in low-income countries, and there was only one published paper at the time, and that was from Uganda. So the first piece, as I say, is the qualitative piece. So what do parents and professionals understand by typical child development? And it's really important to look at that first before you start thinking about atypical patterns of childhood development. I also was interested in whether or not they could identify atypical developmental patterns, and if so, what terminology would they use to describe those? And then what do they think the causes of those might be? And what should be done to address them? And these questions came out of a story that one of our field workers told us, which was, yeah, frankly, just really, really upsetting. So they spoke about a child that they had come across who was locked in a shed in the side of the house. Behaviorally, they weren't safe to be left alone, but the family needed to go out and work the fields, and so couldn't leave the child alone, so they left the child there. And there was a lot of stigma and shame associated with having a child with abnormal child development and atypical child development. There was no diagnosis, so it wasn't, we couldn't be clear what it was that was causing it. So what did we do? We did quite a large qualitative study, actually 12 focus groups, 9 semi-structured interviews of 106 participants in total. We purposefully selected parents who were either of children who were typically developing or had a recent diagnosis of autism. And that work was done with the only NGO working in Nepal on autism, called Autism Care Nepal. And they had a group of around 110 children that they cared for in Kathmandu. And then I also purposely sampled a group of professionals, so paediatricians, teachers, community health workers, early child development workers, and traditional faith healers. The topic guides were translated, piloted and revised, and the analysis was done through thematic analysis and NVivo. So I mentioned that we wanted to see whether our participants were able to recognise or identify a child as having unusual or atypical child development. And so the way we did this was through a series of vignettes. And we worked with a local artist in Kathmandu who painted a series of stills of certain types of behaviours. So we had 7 vignettes, 4 autistic children, 1 with ADHD, 1 with global developmental delay. Apologies for the abbreviations there, I should have spelled those out. And 1 typically developing child. The questions were, could they identify them as being atypical or neurodiverse, and then how could their needs be better met. So what we found was that most families and professionals could describe typical developmental milestones, and many were able to describe how children learn. For example, one community health worker said seeing others doing and doing by themselves. In terms of the atypical or the unusual or neurodiverse childhood development, there were 4 main themes that came out of the qualitative data. Firstly, around perceptions, causal attribution, social consequences, and capacity building. But I won't go into all of those in great depth. The majority were able to identify behaviours described in many of the vignettes as being atypical, but they weren't able to attribute specific terms or labels to these types of behaviours, and that's both from the professionals and the families. In fact, the only group that were able to ascribe a specific term to the autistic children were the families of the children who'd had a diagnosis of autism already. But they did use some distinctive terms for the behaviours that were different between autism, developmental delay, and ADHD. So this is a word map. It shows the words that we use to describe each of the vignettes. The size of the circle denotes the frequency by which that term was used. So here, this was the vignette of an atypical child development a vignette describing an autistic boy. And as you can see, the most common terminology used for that was that he was stubborn. A lot of these phrases are quite derogatory and negative in interpretation, which was interesting in and of itself. So words like foolish, stupid, dull, arrogant, half mind, disobeying, special child, weak mind were used. The yellow autism there with the asterisk denotes the families of the children who'd got a child with a diagnosis of autism, and they were the only ones who could who used that term. For the child with ADHD, no one was able to, only I think 2 people were able to identify this child of having ADHD. And again, it was the families of a child with ADHD and autism. But here, again, the quite negative words, doggedly, mischievousness, insisting, pampered, naughty, stubborn, all very negative. The vignette on describing the autistic girl. So this was really interesting in that nobody recognized this girl as being autistic, and the overall sort of the most common descriptor was of being shy. But again, some other more negative words like mentally retarded, egoistic, depression, slow mental development. For the boy with developmental delay, again, relatively negative terminology, dumb, dull-minded, slow-minded, but then some more standard terms that are more accepted within the Nepali context, like intellectually impaired and mentally retarded. So moving on to causal attributions, broadly speaking, these were divided into 2 areas, so 2 sub-themes of external and internal locus control, and that really sort of defines on whether or not the parents and the professionals felt that the causation was within their control or not. So those within the external locus of control included things like birth complications, genetic fate, and unknown. But there was quite a significant focus on internal locus of control. And I'm sure you won't be surprised to hear that the majority of that was felt to be the fault of the mother. So the mother going to the temple at the wrong time, or watching television or inappropriate television, or giving the child the wrong diet, or herself being anxious and then causing this child to have autism. So very much going back to theories that were sort of around much more in the 70s and 80s in high resource settings around it, you know, for example, the refrigerator mother theory. So in terms of, these are just some of the quotes. So this is one of the community healthcare workers who said it's the parents' role to make their children normal. And again, in the first, one of the primary teachers saying first school for children is home. So really very much about it being the parents' fault, if you like. The social consequences, there was, I mean, some really heartbreaking narratives, largely negative impact of having a child with autism. But really strongly, the theme that came through was that there's really very limited training in patterns and management of child development. And the parents and professionals call for wider awareness in autism through media awareness campaigns and need for educational support. So I'm actually going to flick through the next section a bit more quickly, because I want to make sure we've got time for questions. But the second part of this study was to, following on from that, estimate the prevalence of autism in Nepal. So we really had to start at the beginning. There was no tool. We had to adapt it, test the acceptability, estimate the prevalence, and then try and check the validity of the adapted tool. So I did a scoping review of the literature. I wanted a population-based tool that could be used in childhood and adolescence, that was freely available, that was short, required parental input, and sufficiently high sensitivity and specificity. And I identified 12, and there was one which was the best fit, which was the AQ10, so the autism quotient 10, which, you know, it's definitely not perfect, but was the best fit for our criteria. So we adapted the tool, and this is a picture of that adaptation. So we work with a group of parents that you can see, and healthcare workers, to look at the wording. We ran 3 focus groups with 28 participants, and then we also asked whether the AQ10 items would be acceptable and straightforward to answer, which they felt it would be. And then we ran pilot and training in Makampur on the left, and also with the mothers. So in terms of the estimated prevalence, from the previous data flow chart that I showed you, I don't know if you remember that we, in the first round of follow-up, we ran the UN disability screening tool, and then in the second round, the AQ10. So out of all of the children, 14 scored greater than 6, which is indicative of elevated autistic or probability of autism. And of those 14, 13 also screened positive for disability. And if it is, if the AQ10 screening tool, and that's a big if, is as sensitive and specific in the Nepali population as it is in the UK, it would estimate, it would give a true prevalence rate of around 3 in 1,000, with 95% confidence intervals around that being 2 to 5. So then we looked at whether this is clinically valid. So we checked the data that we had for disability against the AQ10. So as I said, 13 of the 14 also screened positive for disabilities, and they also screened positive for difficulties around communication, relationship forming, and coping with change. The gender ratio was 1.4 to 1, so majority male. More than 70% didn't attend school, compared to 4% of the cohort who screened negative for disability or autism. More than 80% had stunted growth, compared to 40% of the cohort. and they were more likely to have cognitive difficulties as measured by forward and backward digit recall, which is a measure of working memory. So significant lack of knowledge, significant stigma, and a huge gap in terms of training and education, particularly in rural settings. So with that estimation, given the population size of Nepal at the time, that would equate to over 35,000 children and young people with autism. And at the time of the study, there were only 107 children with a known diagnosis of autism in Nepal. So that represents a huge unmet need and also a likely underestimate. Really significant that the majority weren't attending school, and the level of stunting was just extraordinarily high in this population. So in conclusion, it's the first study to examine parents' professional understanding of autism, clearly showed lack of awareness, and there's sort of important implications for future work. But then at the same time, we were also looking to do some comparative work across UK and Japan. So we did actually get ethics to run the qualitative study both in the UK and Japan at the same time as I was working in Nepal. But we just, through various reasons, the PhD student who was working in Japan was unable to complete the study. And so we weren't able to do that work. It's something that I'd really like to do in the future. And then our next steps really were to think about intervention development. But this sort of idea of tri-country comparison remained very sort of firmly in our heads. And as these things sometimes do in academic work, you know, you wait a while and then things start to sort of come together. So what we did was, after I'd sort of published this data, working with Georgia, a colleague at QMUL, and also colleagues at Birkbeck, we got a small amount of funding to go to Tokyo to present the data across that we'd had thus far. Unfortunately, after that, COVID hit, and this has been on pause since then. But I just wanted to highlight one presentation that's kind of stayed with me the whole time since that, and that was from a colleague, Shin, who has got significant physical disability, and also one of his colleagues who's autistic. And they spoke to us about a participatory action learning research method called, I'm probably going to say this completely wrong, but Chijisha Kenku, where they use research as both an exploratory academic tool, but also as a therapeutic tool. So it's user-led research where, so for example, they might think about eye gaze and facial recognition and describe, so one of the researchers described how she would piece together somebody's face when she was looking at them, and so then explored that in more detail as a hypothesis. So it's something that I've not seen done in the UK. It would be interesting to see if anybody else has. So through that, we applied for a Wellcome grant. We weren't successful to do some global research on autism, culture and society. I was very much a small part of that, really very much led by Atsushi and Georgia. But it's still percolating there in the background as something that might be interesting to take forward. And really sort of growing from that, but also from the work that I do on the NeoTree, which is a digital health service intervention. David Skews at ICH approached me about working with him on trying to develop a blended, so using the digital learning that we'd had through the COVID pandemic, where we moved our autism assessments online. So to use the learning from that to try and develop an autism assessment tool that would be more efficient, but still retain the high quality that it had, but also really crucially for a setting such as Newham, be tailored and appropriate for use in an ethnically diverse population. So all of the autism tools that we have for assessment have mostly been, developed with white, English-speaking, American or UK children, and that's not necessarily appropriate for all populations. So this is a piece of work that we started recently, funded by the Patrick Paul Foundation. And again, nothing that we ever do, that I ever do, is ever on my own. So this is a real team effort, and I know Shamina's on the call. So, watch this space. What we're looking at is we're, as I say, trying to build on our experience over the last couple of years through COVID. We've recognised that we have a huge gap in terms of our health service provision. We have really unacceptable waiting lists, and also our autism assessments are not sufficiently nuanced to be able to be helpful in culturally diverse, but also socially deprived populations. So we want to be able to think about diagnostic overshadowing and how we can develop tools that are really much more clinically specific. So the other thing that we are interested in is making sure that these tools are open source. I don't know if those of you who might know, but the ADOS, a lot of the tools that we use are US based and are charged at exorbitant fees to the US company, including the kit and the training and everything else. So we want to develop something that will be used for other people. So another acknowledgement slide before I finish. As always, huge thanks to everybody involved, and thank you for listening. I'm happy to take any questions.
Thank you, Michelle. That was a really great presentation. I'm going to start off the questions while everyone sort of thinks of some, because I don't see any on the Slido at the moment. One is, how do we change the narrative or public perception of children who are neurodiverse globally or in different countries such as Nepal?
Ooh. It's a really, really good question. The thing, I don't know the answer. I think the answer lies in taking a really collaborative approach to trying to understand, where culture, where the stigma and the understanding and the perceptions come from. I think that, and we have to do that whilst talking to communities and families and, faith leaders or kind of leaders within communities. I suspect it's not going to be a simple answer. It's not going to be a simple answer that will be one size fits all. So I'd be interested to hear what other people think.
Absolutely. I don't think it is a one size fits all. I think it takes it's cross sector, and also doing very innovative things, like you said, working with traditional faith healers, etc. Does anyone else have any questions or want to feedback onto that?
I don't know, but Shamina might have. So I have mentioned Shamina, but she's our lead for autism in Newham and is doing some really, really good work around just that. So trying to push forward our understanding of the sort of intersectionality between culture and neurodiversity. So Shamina, do you want to add?
Yeah, just say thanks as well, Michelle. I know you've mentioned this research many times when we've talked, but it's really powerful to see you voice it and to hear some of those stories. I think as a consultant in this area clinically, anecdotally, we have seen exactly what Michelle is talking about in Nepal, in our ethnic minority populations in Newham, and there are a variety of different ethnic groups. Probably our largest group is a Bangladeshi Muslim population here in Newham. My curiosity and interest, and hopefully a research project will come out of it, is to think about those families being able to tell their story. So I think one of the challenges is that we know that there's stigma, and we know that there might be negative words that are being used to describe autism, so not the kind of neuroaffirmative, neuropositive approach, but it's coming on the journey with them. How did they get there? What were the influences? And so I think it's really important to be able for them to tell their story and really tell their story. So, beyond even kind of what we normally do in research, which is kind of look for themes, but actually get them to say where they came from and how they got here. And the families that are doing really well and have accepted a diagnosis, what was the things that made the difference? So I think it needs to be more in-depth research, which we're hoping we can do with our families in this area, because otherwise we're not going to be able to move forward. I think another fascinating thing which Michelle has said is this perception, and even in, I think, Somali families who've been studied in the UK, this is the same thing, that autism is a Western disease. And so what our curiosity is how would this be understood from their cultural norms and perspectives? And I think that's the thing. It's about opening the door for them to be able to talk about these areas. And sometimes, it can be in a positive way. Certainly some studies of Muslim populations in the UK have talked about how they feel that this is something that was given to them by Allah, and they have to, in a way, support their child because this is their journey, and they will be rewarded for it, for doing this kind of service to humanity and to their family. So, there are ways in which we can explore these things in a positive way, but if we use very old-fashioned, maybe Western norms with these families, then we're going to push them away. So I think it's about working together. And I think it's also about using in other innovations like the arts. So I think one thing that was wonderful is in Michelle's study, they used this local artist to depict the different scenarios for the topic guides. And, whether we can use the arts to help families express what they're feeling if they can't express it in the conversation. So whether it be poetry or theatre, perhaps, or, film or music, there's very rich traditions in many different ethnic groups in the arts, but we don't often explore them. So that's something that I'm quite interested in doing with our group here. So those are just sort of some of my perspectives on where we might be able to go with it.
Oh, that's great. I'm interested in that too. I'm doing research with families in temporary accommodation in Newham, and a lot of the families that I've come across working with professionals have autism and have really struggled during the pandemic because of being locked down. And if you can imagine temporary accommodation, it's very small and being in one room. So I think that's also something to explore and look at. Does anyone else want to feed into that? Because I could talk about this all day.
No, I just wanted to add though that I did all that work on a shoestring. So I think I had £30,000 or £35,000 for my field work. And it was, costs of things in Nepal are relatively cheap, but it was still, we were able to do an awful lot. And a lot of that was driven, the fieldwork team went the extra mile, because they felt it was really interesting. They'd worked in Macklemore for years, but nobody had ever talked to them about disability or hidden disability or neurodiversity. And it was almost, they described having their eyes opened to it. And they came back, they kept coming back with stories or families that they'd met, or things that they thought were that could be changed. And part of for them was, why has nobody ever spoken about this to us before? Why haven't we seen this before? Because the initial assumption was, this doesn't happen here, we don't have it because we don't talk about it, there is no word for it, there is no autism. But actually, when we did the screening, when they went to the families, when they spoke to the families, they found that wasn't the case. So yeah, anyway.
Does anyone else have any questions?
Yeah, hi, I'm Helen, I'm one of the registrars. I was just wondering, Michelle, alongside the sort of communication with the family and understanding what the family felt about it, when you were setting up the study, was there any resistance at a sort of organisational level in local authorities or the health services, or anything you came across where people were kind of not just denying that it existed, but kind of in any way obstructive to the research going on?
No, I think I was Dharma Manandar, who was my supervisor from Nepal, who sort of led the mother and infant research, is a really kind of well-known senior person. It's a very, very hierarchical, difficult as a white woman, a doctor. The doctor bit worked in my favor. I think because of that, I was able to get things done that others had not been able to do. It wasn't easy, but because of he was really supportive, and this was something that he really wanted to do in terms of not necessarily the autism piece, but he wanted to do the long-term follow-up study. So this was nested within something that he really wanted to do. So I was able to sort of fly slightly below the radar on some of this work because it was part of something bigger. I think the main thing was just slightly dismissive. People were slightly dismissive to start with, that actually kind of they're there. Almost like, yeah, that's great, but we're not going to find anything interesting kind of approach, because we don't have it here. There's not, this is not our problem. Not quote unquote, but that was the and you always have to be a bit difficult. That was what I perceived the narrative to be, and it may not have been that, but that's what it felt like to me. So no problem at all. And mainly people were just shocked and felt that actually this helped take that conversation forward around training and education. I only wish I could have done more there, but I just, haven't been able to take that forward afterwards.
Thank you.
Does anyone else have any questions? I have another question if no one's going to ask one. So you're talking about the underestimate of prevalence. So what screening tools do you think can be implemented on a larger scale to address this? I'm sorry, I'm asking the really hard questions.
No, it is a really good question. So I honestly, I don't know. So I had money. I had ethics to do a second in-depth clinical assessment of 100 children. So one of the pediatricians was going to come and do a developmental assessment for 100 children, and then whatever it was, 85 children who screened negative. And we were going to run a whole sort of gamut of other screening tools at the same time. I had no money, I had no field costs to do that. So it never got done. And that's the other thing to kind of, research, sometimes it works out the way you want it to do, and sometimes it doesn't, and sometimes it's just you do the best you can. And this was definitely one of those projects where I did the best I could, I would have loved to have had a more in-depth assessment and being able to work more towards a better screening tool. But the UN Washington Childhood Disability tool is probably the best known epidemiological screening tool for disability, and it has more of those questions at the end now around coping with change, relationship difficulties, those types of questions. So that's probably the kind of most known wide scale community level screening. But yeah, I don't know, there's a whole research thing. So Georgia, who's not here, one of our colleagues has worked a lot in Delhi, looking at within clinics though, looking at things like eye gaze, eye tracking, trying to think about autism assessment within children in Delhi, and then looking to compare against cohorts within the UK. So they've got a lot of data within Birkbeck. Yeah, there's a whole like field of research there.
Yeah. Any other last questions? Okay, I'm happy to wrap up. Thank you, Michelle, for being part of the Disability Visibility Seminar Series. It's been fantastic having you. This is really brilliant work. Just to let everyone know, the next two seminars are going to be on May 18th and 19th, and the invites will go out for those via Outlook. Thanks, everyone. Thanks, Michelle.
Thanks for listening, guys. Take care. Thanks, Diana.